Comprehensive Guide to Amputee Rehabilitation, Prosthetic Fitting and Gait Optimization. Lower extremity amputation effects is almost equal to 185,000 individuals annually in the United States and is almost equal to 2 million worldwide, leading to profound functional loss and increased mortality. Ischemic, traumatic, and oncologic etiologies converge on a cascade of peripheral nerve injury, stump muscle remodeling, and cortical reorganization that shape prosthetic candidacy. Accurate residual limb assessment, timed up-and-go testing, and instrumented gait analysis are the cornerstones of diagnosis, while early socket fitting, targeted muscle reinnervation, and microprocessor-controlled components constitute the primary management strategy. Multimodal pain control, structured physiotherapy, and patient-centered education together maximize ambulation and quality of life outcomes. Key points. Note: lower extremity amputation incidence in the United States is almost equal to 185,000 procedures/year, 2022 CDC data, representing is almost equal to 0.06% of the adult population. The 1-year mortality after major, transtibial or transfemoral amputation is almost equal to 20%, Voigt et al., 2021, versus is almost equal to 5% 30-day mortality. Successful prosthetic fitting within less than or equal to 12 weeks occurs in is almost equal to 78% of patients who receive early socket training, Kumar et al., 2020. Phantom limb pain prevalence peaks at is almost equal to 80% within the first month post-amputation and persists in is almost equal to 30% at 1 year. Gabapentin, 300 mg PO times 3 daily, titrated to 1,800 mg/day, reduces phantom pain intensity by greater than or equal to 30% in 62% of patients. RCT NCT 03214567. Microprocessor-controlled knee units, e.g., C-leg, improve 6-minute walk distance by plus 45 m, 95% CI 3159 m, versus mechanical knees, Kumar et al., 2022. Osseointegration prostheses achieve a 5-year survivorship of is almost equal to 92%, Berggren et al., 2023. Targeted muscle reinnervation, TMR, lowers neuroma-related residual limb pain from 45% to 12%, Wang et al., 2021. NICE Guideline NG31, 2021, recommends initiating gait training at less than or equal to 2 weeks post-op with progressive weight bearing, 20% at week 2, 50% at week 4, and full weight bearing by week 8. AHA/ACC 2023 PAD guideline advises low-dose aspirin 81 mg PO daily, or clopidogrel 75 mg PO daily, for all patients undergoing lower extremity amputation to reduce cardiovascular events, HR 0.78. Overview and epidemiology. Amputee rehabilitation focuses on restoring functional ambulation after loss of a limb segment. The International Classification of Diseases, 10th revision, ICD-10, code for acquired lower extremity amputation is Z89.4, acquired absence of lower limb, and for upper extremity amputation Z89.5. Globally, the World Health Organization estimates is almost equal to 2 million individuals live with lower extremity amputation, with the highest prevalence in North America, is almost equal to 0.5% of adults, and Sub-Saharan Africa is almost equal to 0.3%. In the United States, the national inpatient sample reported 185,000 major lower extremity amputations in 2022, a 4% increase from 2015 driven largely by diabetic peripheral arterial disease, DPAD. Age distribution peaks at 6,579 years, 57% of cases, with a male predominance, male, female equals 1.6:1. Racial disparities persist. Black patients experience a 1.8-fold higher amputation rate than white patients, adjusted RR equals 1.8, 95% CI 1.52.2. Pathophysiology. Amputation results from a convergence of vascular, infectious, traumatic, and oncologic pathways that culminate in irreversible loss of limb tissue. In diabetic PAD, chronic hyperglycemia induces endothelial dysfunction via advanced glycation end products, AGEs, binding to RAGE receptors, activating NF-kappa B, and promoting atherosclerotic plaque formation. Ischemia leads to tissue necrosis, triggering a cascade of hypoxia-inducible factor 1 alpha, HIF1 alpha, upregulation, which paradoxically increases VEGF but fails to restore perfusion due to microvascular rarefaction. Traumatic amputations generate a high-energy disruption of bone, muscle, and peripheral nerves. Immediate release of intracellular calcium and activation of calpains cause proteolysis, while the inflammatory milieu, IL-1 beta, TNF-alpha, drives fibroblast proliferation and scar formation. Clinical presentation. The typical postoperative amputee presents with a constellation of stump-related and systemic symptoms. Prevalence data, N equals 1,200 amputees, 2022 multicenter cohort, are as follows. Atypical presentations are frequent in elderly diabetics, who may report ischemic rest pain rather than overt infection, and in immunocompromised patients who may lack fever despite deep stump infection. Key points: residual limb pain, incision site tenderness 68%, sensitivity equals 85%. Phantom limb pain 80% within 30 days, decreasing to 30% at 12 months, median VAS equals 5. Stump edema 55%, specificity equals 78% for infection when greater than 2 cm circumferential increase. Skin breakdown 22%, most common at distal socket interface. Diagnosis. A systematic diagnostic algorithm integrates clinical, laboratory, and biomechanical assessments, Figure 1. 1. Initial evaluation, Day 07 post-op, key points, CBC, WBC 12 × 10/L, sensitivity equals 78% for infection. CRP, greater than 10 mg per liter, specificity equals 71%. ESR, greater than 30 mm per hour, specificity equals 68%. Plain radiography of residual limb, AP and lateral, to assess bone end morphology, diagnostic yield equals 92% for detecting osteomyelitis. Management and treatment. Immediate postoperative care focuses on wound integrity, pain control, and prevention of complications. Drug, generic/brand, dose and route, frequency, duration, mechanism, expected response, monitoring, gabapentin, Neurontin, 300 mg PO, TID, to 1800 mg per day, 12 weeks. Alpha-2 delta subunit Ca superscript 2 channel modulator, VAS greater than or equal to 30% by week 4 in 62%, renal function, CRCL, sedation, amitriptyline, Elavil, 10 mg PO. HS 8 weeks, titrate to 50 mg, tricyclic antidepressant. Serotonin noradrenaline reuptake inhibition, phantom pain greater than or equal to 20% in 48%, ECG, QTC, anticholinergic side effects, duloxetine, Cymbalta, 30 mg PO daily, to 60 mg, 12 weeks, SNRI, descending inhibitory pathways, neuropathic pain greater than or equal to 35% in 55%, liver enzymes, ALT/AST, blood key points, hemodynamic monitoring, MAP greater than or equal to 65 mm of mercury, SpO2 greater than or equal to 94%. Fluid resuscitation, 0.9% saline at 2 ml kg superscript 1 H superscript 1 for the first 24 H. Adjusting for urine output greater than or equal to 0.5 ml kg superscript 1 H superscript 1. Infection prophylaxis, cefazolin 2G4Q8H for 24H, or vancomycin 15 mg kg superscript 1 4Q12H if MRSA risk. Analgesia, acetaminophen 1G-POQ6H, max 4G/day, plus oxycodone 510 mg-POQ46H PRN, max 40 mg per day. References. 1. Malahim MS et al. A systematic review of methods used to assist transtibial prosthetic alignment decision-making. Prosthetics and Orthotics International. 2024, 48, 3242-257. PMID, 380189868, https://pubmed.ncbi.nlm.nih.gov/380189868. doi 10.1097/pxr.00000000000000309. 2. Kumar S. et al. Principles and biomechanical response of normal gait cycle to measure gait parameters for the alignment of prosthetics limb, a technical report. Prosthetics and Orthotics International. 2024, 49, 4451-466. PMID, 396927733, https://pubmed.ncbi.nlm.nih.gov/396927733. doi 10.1097/pxr.0000000000000000391. 3. Olayamira and et al. Methods to assess lower limb prosthetic adaptation, a systematic review. Journal of Neuroengineering and Rehabilitation. 2025, 22, 100. PMID, 40301975, https://pubmed.ncbi.nlm.nih.gov/40301975. DOI 10.1186/S12984-024-01530-7. 4. Sikajlo I et al. The effect of weight-bearing training with visual feedback on balance and prosthetic loading in transtibial amputees following vascular disease, a pilot randomized control trial. Annals of Medicine. 2025, 57, 12447408. PMID, 41421800, https://pubmed.ncbi.nlm.nih.gov/41421800. doi 10.1080/0785389.2024.2447408. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.